So let's think about the possible consequences of coronary arterial atherosclerosis if there's atheroma in the coronary arteries. So here we have coronary arterial atherosclerosis. That's the pathology. What clinical features can be generated? Well, if the plaque is stable, that can give rise to chronic stable angina. This is caused by ischemia. So when the atheromatous plaque gets big enough to block off the lumen of the artery to such a degree that the patient starts getting pain or breathlessness on exertion because the myocardium is ischemic, that is chronic stable angina. But if the plaque is destabilized, that can generate thrombus formation. And when you get thrombus formation in the coronary artery, this happens acutely, and this gives rise to the acute coronary syndrome. So this is caused by thrombus developing in a coronary artery. The patient will complain of a history of recent onset of severe chest pain, typically, and they'll present as very ill patients with pain or sometimes breathlessness, but usually the typical myocardial pain. Very distressing, very ill patients. The examination of these patients consists of a 12-lead ECG, and we need to test for troponins. And there are 3 degrees of severity of acute coronary syndrome. What you might call the mildest form of acute coronary syndrome is unstable angina, sometimes called troponin negative acute coronary syndrome. So here we're going to have white thrombus reducing the blood supply, causing clinical features, but the reduction in blood supply to the myocardium is not sufficiently severe to cause the release of troponins, nor will it cause ST elevation. But if there's more white thrombus in the coronary artery, then there will be enough occlusion to cause the release of troponins, but still not enough to cause ST elevation. That's why we call this a non-ST elevation myocardial infarction, or a non-STEMI. But if red thrombus develops in the coronary artery, then that's going to give us troponin release, and it's going to give us ST elevation myocardial infarction. So red thrombus is going to cause STEMI. And actually, if there's a new left bundle branch block presenting, we classify that as a STEMI as well. And this is very important to know about, because although these patients will all need the treatment for acute coronary syndrome, those with STEMI, so those presenting with the picture of an acute coronary syndrome, ST elevation and troponin release, are going to need immediate reperfusion or PCI, percutaneous coronary intervention, or thrombolysis to open those arteries up again to get the blood supply back to the infarcted myocardium before those myocardial cells die. And it's important to realise that this unstable angina can develop onto non-STEMI. Non-STEMI can develop onto STEMI. That's why treatment of the acute coronary syndrome is always an emergency. These always need treated. But because we know that this one's typically caused by white thrombus, and this one's also typically caused by white thrombus, that we only need to thrombolyse the ST elevation myocardial infarctions. Preferably, we will do immediate PCI if that's available. That's associated with the best possible prognosis. If emergency PCI is not available or would be delayed, then these patients need thrombolysed. So remember, 3 components of the acute coronary syndrome: unstable angina, non-STEMI, STEMI.